for local administrations. In this context, the One Health approach, built on the recognized interdependence of human, animal, and ecosystem health, becomes an essential tool for healthy cities. And I want to be precise here. One Health is not merely a conceptual framework, it is a working method, a way of governing the genuine complexity of urban health in an integrated and practical way. This vision fully aligns with the manifesto Health in Cities, a Common Good, published by the Health City Institute in 2025, which frames urban health as a collective right and identifies 10 areas of action: health literacy, health education, healthy lifestyles, food culture, access to sport across all age groups, sustainable mobility, prevention of chronic disease, inclusion of vulnerable populations, and monitoring of health determinants, and the building of alliances between institutions, universities, and research centers. This same logic drives the One Health Department of the Italian Ministry of Health, which has formally endorsed the manifesto. Drawing on the One Health Joint Plan of Action of the quadripartite, an accord in the Sustainable Development Goals of the 2030 Agenda, the department has developed a model structured around three dimensions. The first dimension is culture and education. On the cultural side, the department has open dialogue on social prescribing with a range of stakeholders, museums, historic residences, sports organizations, on the awareness that art and beauty, together with physical activity, are a powerful tool for a healthy lifestyle, embedding One Health philosophy directly within the urban communities. On the educational side, we are promoting the One Health approach, working with the WHO Regional Office for Europe and the One Health Collaborative Center at University College of Dublin. And let me say hello to Tony Orwan, with which we are working together. We are working on training modules for health professionals, as well as with the WHO Academy in Lyon on the One Health Game Changer, a project for secondary schools designed to help young people understand what it truly means to work together across disciplines for a single shared health. The second dimension is equity, a central challenge in urban health policy, ensuring that health truly is for everyone and no one is left behind, that vulnerabilities are not uniformly distributed. Older adults, people in detention, and children in distress live at the intersection of biological, environmental, and social determinants that only an integrated approach can properly address. The department has invested in pilot programs in prison healthcare, and together with the Department of Juvenile Justice of the Ministry of Justice, is developing experimental protocols for integrated social and health services. On the challenge of aging, a crucial issue for any city that aspires to be healthy, the department promotes active aging as a systemic prevention strategy, one that is attentive to accessible urban design and to the social determinants of health, with the goal of building cities that are more equitable and inclusive across all generations. The third dimension is the proactive prevention. It focuses on territorial scalability and the building of cross-sectoral alliances, consistent with the manifesto's call for a strong alliance between municipalities, universities, health authorities, research centers, industry, and professionals. The department actively participates in the work of the technical committee supporting the parliamentary intergroup on One Health, applying this methodology to the regeneration of the urban-rural continuum with integrated indicators for the joint monitoring of human, animal, and environmental health in support of policy guidelines that simultaneously address ecological sustainability and ecosystem quality. A key operational instrument in this area is the Environment and Health Program. Through these projects dedicated to biodiversity, climate and health, The program represents a concrete step toward integrated urban health governance. It recognizes that climate change and biodiversity loss are primary health determinants in cities and identifies interinstitutional alliances under the One Health approach as the tool to cope with it. From the surveillance of chronic diseases aggravated by air pollution to the prevention of heat-related illness to the promotion of healthy urban environments that can actively counter sedentary behavior and social isolation. In this context, I would like to highlight the BEPS project, Green and Blue for Health, a national research project designed to scientifically validate the role of green and blue urban infrastructure, parks, urban forests, rivers, coastlines, as genuine determinants of public health. The project's ambition is not merely academic, as it aims at embedding nature-based health promotion directly into national health policy. To date, the results are encouraging. Systematic reviews and case studies, including work carried out in Rome, are confirming a positive association between children's exposure to green school environments and measurable improvements in working memory and attention. We are also documenting protective effects of natural spaces for elderly and vulnerable populations, particularly in the context of heat stress. WEBS is just one example of how we are trying to bridge the gap between urban planning and public health. Urban policy is health policy. Every investment in the integrated health of our cities is an investment in the resilience and in the well-being of everyone who lives in them. So I thank you again for having invited me, and I wish you all the best for this webinar. Thank you.
Thank you so much, Mr. Leonardi, for setting the scene so eloquently and for so generously sharing all the work that you are doing, not just in Italy, but also with that global lens. And of course, also for your long-standing commitment to really scale up One Health approach. But I also want to thank you for also reminding us that if we are to be successful, we of course also need to put equity at the front, right, and center of our efforts. So I really appreciate this, Mr. Leonardo. You really set the scene very eloquently for us. And that now leads us to the next part of the webinar, where we will be honing in much more on the regions, on the cities, as well as that of the municipalities. So with that, colleagues, I'd like to thank you, Mr. Leonardi, again for your commitment to really scaling up a One Health approach. And I'd like to now turn to the first part of our webinar, where again we'll be honing in on the regions. And with that, I am delighted to invite our next speaker, who is Anna Mastakaracou, who is the Deputy Regional Governor for Public Health in Western Greece. Anna is not only a long-standing member of the Regions for Health Network, she's also a change maker and really deeply believes in the importance of applying a One Health approach. And Anna will be speaking to us about the work that they're doing in Western Greece on One Health in the context of emergency preparedness. So with that, over to you, Anna.
Thank you very much, Kira. Thank you for this opportunity, and also let me welcome all the participants today. It is a great honor for us, for the region of Western Greece, to contribute to this important discussion about One Health in action. Let me share with you. Okay. Presentation. Do you see it?
We see it, Anna.
Okay.
Maybe you can put it in presentation mode.
Let me do it again. Do you see it now?
You are not in presentation mode at the moment.
Now?
No.
No. Let me see.
Can you click, there, the present?
Yes, I click here. I'm in my screen. I am in presentation mode. Do you see it?
No.
No.
But maybe we go ahead because we can see the presentation.
Okay.
Maybe we go ahead.
Okay.
Even though we
Okay. Do you see it now? Now, we are gathered here under a shared discussion, understanding of the challenge we face today, climate change, pandemics, environmental degradation, complex emergencies. These are not longer isolated events. They are interconnected, systemic, and increasingly frequent. And this is precisely where the One Health approach becomes not only relevant, but essential to everything of us. We're starting to move from fragmentation to integration, and this is a very important movement. Everything about One Health, I think you see the next slide, is a complex ecosystem. We have human health, animal health, environmental health. These issues have evolved in parallel with limited coordination and interoperability. Health threats do not respect institutional boundaries, and this is the problem. Now, in Western Greece, we try to have a platform, to have a strategic plan how to work with One Health. So we have a 5-pillar model. The first pillar for us was an internal unified region, a platform in our region, putting together in the same table different scientific fields to talk to each other, public health services, environmental services, veterinary services, everybody talking to each other, so we can make a movement to break down internal fragmentation and ensure that we have a coordinated One Health response capacity, especially during emergencies. Our second pillar is the strategic memorandum with the University of Patras. A formal partnership now we have with the university supporting scientific evidence generation, research, translation into policy, and evidence-based policy making. That is what's very important for us, to have effective public health decisions that must be grounded in scientific evidence. Our third pillar is a national unified health network, bringing regional authorities together, health institutes, public health bodies, and research and policy stakeholders, because we think that coordination beyond regional is very important in health emergencies. The fourth pillar is about people. We were talking with patient association, community groups, NGOs active in health, environment, and community care. And here we have we think that community engagement is very essential for effective emergency preparedness and response. The fifth pillar is connecting region with cities. It's very important to us to have a vertical governance mechanism with regional authority, municipal administration, because all emergencies are local and preparedness must be local as well. Now, last year we were working on this project, very enthusiastic, and on August, surprise, surprise, we have a mega fire in Patras. So we have an emergency crisis. Within hours, we have thousands of hectares burned around the city, within the city. Homes, infrastructure were damaged. Agricultural and livestock sector were affected. And we are very fortunate that we have no life lost, but public health consequences were very severe. We have respiratory problem due to air pollution, water contamination, environmental exposure to toxic substance. It was not just an environmental disaster, it was a public health emergency. So we have to deal at that time with many issues. The One Health Network was very good tool for at that time because we didn't have time to think about it. We put every scientific field to work together. So we have to ensure that we have water safety, monitoring air quality and toxic emissions, managing the animal disposal, agricultural risks. We have 550 vehicles burned with toxic emissions and a very difficult situation. We had to map everything, every potential risk areas, covering livestock units, boreholes, cultivated area. So, for our experience, our network, One Health Network works. It was very helpful at this moment. But the first barrier was to have to put public health guidance in front line. It was not obvious. We make we tried very hard to put this timely public health guidance in first line. We must strengthen the resilience of the health system altogether. This requires strong state financing and infrastructure.
Sorry to interrupt you. I'm sharing your slide because we were not seeing them well.
Okay.
Can you tell me which slide you have?
It's the one from last. Yes. Okay. So, environmental impact research cannot be optional. We have now ongoing study about environmental impact from the fire. Community training was very important because community all work together in this field and collaborating with each other. We had a spirometry program in order to detect the lung damage because we have a very big issue about this. So it was very helpful for people. And we think that we have to work together as an European climate change hub to have knowledge on the field, expertise. It's very important expertise to be on the field. The disasters and health emergencies are very complex situations, so we have to have expertise on the field and exchange good practices. Closing, my message is that One Health is not only a scientific concept, it's a governance responsibility. One Health is not only about understanding connections, it is about governing those connections effectively. At our time, fragmentation must be moved to integration, isolation had been moved to collaboration, and reaction had to be moved to prevention. For our region, it was very important to have this One Health path, and we're working very hard about it, and it's a concept into a daily operational reality. Thank you very much.
Thank you so much, Anna, and apologies for having a few technical glitches there. I think we managed, and you, of course, very eloquently also shared with us how you've managed to, again, really transition from fragmentation to integration by using a very practical example of how you've applied the One Health approach in Western Greece. And of course, your point is well noted about the need to really hone in on governance. Governance is absolutely essential in applying a One Health approach successfully. You also mentioned the importance of connecting regions with cities. So in that sense, that leads us to our next presentation, which will be shared by Denise Cahill, who is the Healthy Cities Coordinator for the city of Cork, and also has a lot of experience in terms of applying a One Health approach in the area of food systems. So Denise, I've had the opportunity to be with you in the city of Cork just last week, where I've seen this firsthand, but I'm going to give you the floor so you can share with your colleagues how you are applying a One Health approach in the city of Cork. Over to you, Denise.
Thank you, Ciara, and I'm delighted to be here this afternoon in an Irish context with you all. I'm going to talk to you about the approach that we're taking in terms of food systems in the city of Cork. So Cork is a designated WHO Healthy City since 2012. We've been doing a lot of work with the network for the past 14 years. And in the last 12 years, we've established a Food Policy Council, which is an interagency structure around looking at the food system. So I guess I have a short time here, so I'm going to fly through my slides, but my contact details will be at the end of this presentation, and I'd be very happy to link in with anyone who wants to hear further details. Just to set the context, the global food crisis, I suppose, meets an inequality crisis in Cork City, as it does, I suppose, in every city across Europe. We currently have a very unsustainable food system, and that's affecting everyone. So it's combining climate change and biodiversity loss. There's rising chronic health conditions, from obesity to undernutrition to cardiovascular disease, diabetes, etc. And we also have deepening social inequality. So that's the context in which we're trying to look at food systems here in Cork. Food insecurity is particularly an issue in disadvantaged areas, and we're seeing that in our city as well. So what we've agreed to do in Cork City as a Food Policy Council is to develop a sustainable and healthy food strategy for the city. And that's combining both, I suppose, sustainability principles with those of health and healthy cities. We did a widespread consultation across the city. We spoke to over 400 people. It's the largest, actually, consultation of this nature in the Republic of Ireland, where we looked and we engaged with both the community and the public, but young people and children, producers, food producers, farmers and businesses, and we also engaged with institutions in the city. So it's been very comprehensive, and we have the full details of that available for anyone who wants to hear more about that. We set out a strategic vision because as a Food Policy Council, we have a range of expertise around the table. It's not just health experts, it's also environmental experts, business experts, local authorities, academics, and of course, community voices and community food growers. So we set out a vision for how we see this strategy developing. And we consulted with the population and with the citizens of Cork and the various stakeholders I mentioned there under this context. And what we got back was really interesting. I suppose the key message of what we heard is that people are really hungry for change in terms of our food system, and that there's a universal desire for local food. The fast food dominance and food deserts in our cities, I suppose this disconnect is really creating, I suppose, an appetite or a hunger for change among the public. And while farmers are struggling to live from their work and make a living in an Irish context from growing food, families also can afford good food. So there's work there that needs to be done. So it basically revealed a city ready for a shift from calorie security to nutritional resilience. 3 ground level realities that were revealed in terms of systemic barriers that exist in the city are economic hardship, both for businesses but also for citizens and households. Infrastructure and planning is a big issue. And then, of course, food literacy and our food culture in an Irish context. So these are very strong systemic barriers that are in place. And this is just to set the context. So we're very keen to look at both nourishing people, but also nourishing nature. And modern food systems are, because they're globalized, they're resource intensive, and they can be very disconnected from our communities. So our alternative and the vision we're developing is community food growing as one element of our actions. And this is the one I'll focus on today. And that's shared neighbourhood gardens, allotment groups, school gardens, volunteer-run urban farms. The ethos of it is local, participatory and rooted in social and environmental well-being. So not just for profit, in fact, more from a social perspective than anything else. So we're in the process of trying to develop community-centered food environments. And I suppose there's a challenge in that in our context in terms of, a lack of social spaces, a lack of public spaces dedicated to food growing. So what we're trying to really push for is greater access to land in a city context for food growing. And this obviously ties in with the food security issue. And planning policy to shift for growing spaces and allotments in new housing estates, protecting local heritage, seeds, soil and water in the process. And what we're discovering as we work at community level is that communities care about that and want to engage on a broad scale. The social connection that comes with food is obviously key to this. So this is where the human, I suppose, input into this approach is critical. So we're trying to implement community food growing spaces using permacultural approach, which basically is conventional, moving away from conventional agricultural approaches, which simplify ecosystems and considers the maximization of yield in terms of food. Permaculture does the exact opposite. It intentionally increases the complexity of the environmental context in which it's operated, and biodiversity naturally flows out of that. So you're not just producing food, you're also working with nature. The mechanism is mimicking natural ecosystems. It reduces disturbance, encourages natural interactions and builds inherent resilience against pests, disease and climate stress without chemical input. And that's the approach that we've been working on to a very successful level in the city. So the multiplier effect of this community food growing approach using this permacultural approach is multiples, as you can see. You can see there's social benefit to that, and we're really starting to see that in terms of community coming together around food growing, food harvesting, but also food sharing, and even thinking about what's going on in terms of the food system and building their understanding of that. In one particular community garden, there's even been, I suppose, a movement around supporting local water systems because of the nature of I suppose, pollution and the level of pollution that exists in water systems around gardens. So it's starting to build this kind of momentum around a one health, thinking about not just the health of humans, but the health of nature, animals and vegetables, and I suppose the biodiversity around the garden. It also brings into an urban context and ecology, reintroducing mixed crops, pollinator-friendly plants and vital green habitats. And that's quite rare in an urban context. So the permacultural approach in an urban context is quite unique and very valuable. We're seeing huge impacts in terms of health, increase obviously in physical activity, but also reducing levels of stress because of nature exposure, and obviously then improvements in diets. And our gardens have a range of people engaged from a range of different cultures and backgrounds and age groups and genders. So we're starting to see a real kind of a connection with the food system through that. And then, of course, we're shortening supply chains, which reduces food miles, enhances equity, access, and utilises composting for zero waste circular systems. Another approach that is starting to evolve in our region is this bioregioning approach, which is led by Bioregioning Southeast in an Irish context. And a lot of work has been undertaken in the southeast of Ireland. And this is about aligning agriculture with local geography. So moving beyond the boundaries that we have around local authorities or electoral districts to where the boundaries of nature work. And this again is about localizing food production. So with the biodiversity approach, or the bioregioning, approach to food systems, this is about growing crops uniquely suited to the local soil and the local climate, reducing our dependence on imported food and supporting seasonal diets. And that really is the ethos of it. It's about coordinating land use across an entire ecosystem. So it's designed to protect the local water system and to reduce polluted runoff. So it's looking at water and rivers at its core. And then there's native and regenerative practices employed in this approach also. Again, utilising native or well-adapted plant species, actively regenerating the landscapes while also producing food. If you want to contrast that to the conventional approach to farming and to food production, I suppose the conventional approach looks at boundaries based on political borders or electoral districts or local authority or municipality borders, whereas this is based on a natural ecosystem. The scale in a conventional approach is reliant on global food supply chains, whereas this is rooted in local regional systems. The method in a conventional approach is mass production, whereas the method for this is place-specific and adapted practices. And the goal in a conventional approach is a focus on efficiency, whereas the goal in a bioregioning approach is a focus on sustainability and ecological balance for all. An example of that is taking place in Cork at the moment, again supported and funded by the bioregioning approach. And again, it's the philosophy, I suppose, comes from a One Health and a bioregioning local ecosystem approach. And that's the Bushy Park Farm, which was a former dairy farm in the North Cork area, whereby John Murphy, the farmer who lives on that farm, has now offered 1 acre of his land for community food growing. And in that project and in that intervention, it's based on the Heron-Boren method, which was developed in the Netherlands. It's about community coming together to grow the food. And through their membership of this approach, the farmer gets a salary. So the need for mass production and high output is reduced because profit doesn't come into it. What you have is you're joining a community food growing project. You're providing the farmer with a salary and you're supporting him in this context to grow the food. So you're contributing your time, and for your efforts, you get a box of vegetables and fruit at a very reduced cost on a weekly basis to feed your family. And this is an approach that we're piloting and that is being piloted in the North Cork region, and that we're supporting as actively as we possibly can through the Food Policy Council in Cork City. So this is the Bushy Park project. These are the members of it for the last year. You can see there's a high amount of vegetables that are being grown. And it's an experiment, and it's an approach that is very innovative. And I guess it's a form of diversifying away from intensive farming systems to allow for local food supply chains. So in summary, I guess our approach is that we're rooted in place, and we want to grow food locally to nurture ecosystems, to connect people, and to build a healthier and more resilient food system, which is our ambition with the Cork Food Policy Council with the support of Cork Healthy Cities. My contact details are here. I'm very happy to engage with anybody who wants to hear a little bit more, and thank you for the opportunity to present this morning.
Thank you so much, Denise, and again for sharing a very concrete example of how you're really putting a focus on that integration of human health, planetary health, and animal health. Back in 2022, the Healthy Cities Network adopted a political statement on One Health with 12 very actionable recommendations. Of course, the City of Cork were absolutely instrumental in shaping those recommendations. It's wonderful to see how these are now being implemented. And I also take this opportunity to share with colleagues that on the 5th and the 6th of October this year, there will be a mayor summit with a focus on localizing the recommendations that will emerge from the Pan-European Commission on Climate Change and Health. So again, colleagues, this would also be an opportunity for you to join us at that summit, but also to see firsthand how the City of Cork is really implementing a One Health approach. With that, colleagues, I'm going to thank you, Denise, and turn to our next speaker. We have heard from the region of Western Greece, now from the City of Cork. Anna spoke about that connection. I'm now going to take you back to the region of Emilia-Romagna, to be very specific, in Italy. And I'm going to invite our third speaker, who's Paola Angelini, who is an epidemiologist from the Public Health Department. And Paola, the floor is yours. Over to you.
Thank you very much. I'm trying to... It is okay. Now I think you are seeing my slides. It's
we
okay.
Are indeed.
Okay. Thank you very much. I'm very glad to be here, and I thank you for the invitation. And I will present you a One Health approach to control zoonosis and vector-borne disease. I'm from Emilia-Romagna region, and where I work in the public health department. And what I am saying to you derives mainly from this important document, the One Health Joint Plan of Action, that has two action tracks on zoonosis and vector-borne disease. And so we have a useful guide to develop a One Health approach to manage this kind of health problems. And zoonosis is an emerging problem, and it's estimated that over 75% of emerging infectious human disease are zoonotic. And there is a problem with the link between animal reservoir and man and the people, sorry, and the problem of a spillover of viruses from animal reservoir to human, and through the amplification by human to human transmission, the problem can become a global problem. So thinking of zoonosis as pathogens circulating between animal and human, but a circulation influenced by local, by climatic and ecosystems. So this kind of problem needs strongly a One Health approach. And so we have to manage zoonosis, we have to understand the drivers of the re-emerging zoonotic disease, because the drivers are ecosystem degradation, the changes in land use and habitat, the changes in due to the climate change, and also the our relations with animals, breeding and movement of domestic animals and cattle and so on. And understanding these drivers allows us to develop risk mitigation measures. And the main mitigation measures are maintaining healthy and resilient ecosystem. We have to reverse or halt biodiversity loss, and we have to regulate agriculture and trade in wildlife and wildlife products. And this is possible through a sustainable and targeted One Health surveillance that can guide us through early warning, that can allows us to organize a comprehensive response targeting animal, human, and environment. And so due to this background, I can show you the Italian experience, and we have a national arbovirus plan developed by an interinstitutional table with a broad participation from many sectors, departments of the Ministry of Health, participation of the regions and the National Research Institutes. And this working group developed a wide-ranging document, a document which seeks to integrate prevention, surveillance, and response, and this is in an approach of health in all policies, because it's a plan who has a strong link with policies from other sectors different from the health ministry. This document focuses on the surveillance of also on the surveillance of new invasive species, because we are afraid, we are worried of the entering of new invasive species, mainly Aedes aegypti. We think that through climate change, the Italian territory can be suitable for the establishment of these very dangerous species. But we have also focused in this plan on the problem of emergence of resistance phenomena, because the use of adulticides and chemicals has developed or has the risk to develop resistant mosquito populations. And so we have to control these phenomena to have some tools to control outbreaks of vector-borne disease. This national plan ended at December 2025, but regions and Ministry of Health decided to prolong the plan for another year. And so in 2026, we are using the previous national arbovirus plan, but we are working, Ministry of Health is working in develop the new plan for next years. I want to tell you some words on the regional experience of Emilia-Romagna regional experience, because we have our regional plan that derives from the national plan. It's a regional plan adopting a One Health approach involving public health, veterinary, entomological, and environment services. We organize a human surveillance, an entomological surveillance, and ornithological surveillance for West Nile virus and Usutu virus. The main goal of our plan is to early detect virus circulation, so to have a rapid risk assessment and adopt measures to control the outbreaks and to prevent the risk of human transmission. Our specific objectives are the early detection of virus circulation, the implementation of preventive measures to reduce mosquito density, the prevention of the risk of human infection through mosquito biting and the substance of human origins. And another important objectives of the plan is to coordinate the management of outbreaks. I want to say you that last year we experienced a large outbreak of chikungunya with almost 350 cases in the region. It was a very difficult challenge to control that outbreak. We have a network, a One Health network, coordinated by the Public Health Department of Emilia-Romagna region, where I work. And this network involves many health sectors. Our 8 local health units with the public health departments and the infectious disease units involves all general practitioners and hospitals that are the front line receiving in charge of detection of suspect cases. That is the beginning of the story to prevent an outbreak. We have we involve the Regional Center for Transplants and for Blood Donation. We have a laboratory, a regional laboratory for test on human samples. And besides these health structures, we involve the Istituto Zooprofilattico for the entomological surveillance and the virological tests on the animal samples, entomological and animal samples. We have a center, a private center, Centro Agricoltura Ambiente, that is an important has an important expertise on entomology, and we involve all municipalities of the region for the preventive measures and for control of outbreaks in case of, and we involve also our regional environmental agency for the surveillance and for the system of meteoclimatic data to forecast the evolution of the season and the evolution of mosquito density. The governance of the plan is based on a small scientific working group that involves entomologists, epidemiologists, public health doctors, and veterinarians. These groups organizes the entomological and ornithological surveillance, define the level of risk in case of viral circulation, and participates on a research project to improve the system. This small scientific working group is inside a regional committee, a larger regional committee that involves all the 8 public health, local public health departments, a representative of municipalities of the region. We have 18 municipalities, the larger of the region, and we have experts from the environmental agency. This regional committee supports the preparation of administrative acts, the preparation of guidelines, organize communication and citizen engagement, manage a website for health education on mosquitoes. Then the governance at a more local level involves local public health departments and municipalities. Municipalities organize standard vector control measures and promote the extraordinary protocol when requested by the local health authority because viruses are circulating. And local public health departments are in charge of the health surveillance system and of case reporting, but also local public health departments support municipalities on vector control. And then we have the 2 regional laboratories I already presented you from one for human samples and the other for animal samples. So, sorry for the animation, okay. The strategy, summarizing the strategy of the plan, I presented here the strategy for Aedes albopictus vector-borne disease transmitted by Aedes albopictus. The strategy for West Nile is a little different because of the differences in virus circulation in nature. But thinking of Aedes albopictus vector-borne disease, we have a strategy based on entomological surveillance and human surveillance. The early detection of human cases is a trigger for the prevention of transmission through substance of human origins, but also for the emergency vector control measures. The entomological surveillance is useful during the emergency vector control measures because we use this monitoring to evaluate the adoption of this measure, to evaluate if they are useful, if the mosquito density is declined under the threshold of risk. But the entomological surveillance is also useful for the ordinary measures to reduce mosquitoes density because with our data we are able to define what areas of what urban areas have larger density, what are the part of the region when the season is declining or presenting, and so on. So it's a very important tool for us, this entomological survey. And I think I go very fast because I think of 10 minutes. I hope
that'd be fantastic.
you have understood. And this is my email. If you want to contact me, I am happy to share more of our work.
Fantastic. And thank you so much, Paola, for sharing the very rich experience of the Emilia-Romagna region and for also really unpacking that very formal mechanism, accountability mechanism you have in place to precisely ensure that there is a strong case of governing. Really, really, truly appreciate it. Colleagues, I'm very aware of our timing. I was going to open up very briefly for questions, comments, but if I could ask you to put those in the chat for now, because we are going to have a shorter time a little later where we can ask specific questions. So colleagues, this really concludes the first part of the discussion where we've heard from regions, we've heard from cities, what a One Health approach looks like in very practical terms, also highlighting the challenges, but again, also the opportunities for further scaling up, but also for further collaboration. We're now going to turn to the second part of the discussion where we will be honing in on the broader aspects of One Health as well as that of partnerships. And with that, I am really pleased to introduce a colleague from across the Atlantic, who is David T. Dijak from the National Environmental Health Associations in the US. I'd like to thank you, David, for connecting from the US. I know it's very early in the morning for you, and for providing us with insights from progress and challenges in the US National One Health Framework. David, the floor is yours.
Thank you so much, Kira. And I never invite me to speak after Anna, Denise, and Paola. That was a really nice overview. I'm speaking to you from a country of almost 350 million people across 6 time zones. The United States is a federated model of governance. In that respect, it's highly fragmented because of home rule issues. That is, many cities and counties want to make their own rules. I am having a little bit of an issue forwarding the slides, so I'm going to continue to just speak. We are currently...
David, we can take over the sharing from our end. So I'm just going to ask Alice and Andreas to do that. So if you carry on speaking, then we will take over.
Sure. And I'm fine if it progresses or not. The place we're at in the United States today is that much of the One Health initiatives, I think in terms of potential, lie with the public health system. This includes veterinarians, but my lens today is one of environmental health. And you may ask why that's the case. If we look at what is in common across a country as large as the US, the environmental health profession is the second largest profession in public health, second to only nursing, Kira. And what we know is that not all, but most of our nurses are in the clinics doing very important clinical work. It is the environmental health profession which is in the field every day. They are in restaurants, they are in farms, they are in daycare, they are at beaches and pools and spas. Oftentimes they administer pesticides or larvicides to control mosquitoes and looking at ticks and other vectors. So what I would like to suggest is that on most days and most communities in the United States, when someone thinks about public health, what they're really thinking about is environmental health. And because our network, our professional network, are in communities, they know local subculture. And yes, there's a lot of local subculture in the US. They know where the risk factors are. They know the regulated community. And I think I'm making the case for systematically involving environmental health throughout the One Health initiative. What we are finding right now in the US is we are migrating. You see the picture in front of you is an isthmus. It's a piece of land that connects two larger pieces of land. And we're currently moving in the US from a highly regulated environment. Just think of the Clean Air Act and the Clean Water Act. Think about the Toxic Substance Control Act. These are the foundational regulatory instruments that really provided the foundation for environmental public health in the US. Today, we're moving into a completely different era, and I would like to suggest we've already entered that era in which it's not regulatory compliance, it is discretion, it is judgment, professional judgment, and it's ethics that are going to be driving the decision-making of public health. And this is a completely new paradigm for many of us that have a bite of the One Health apple. It is important that we understand there may not be a law or a statute or a regulation. The world is completely different. From a national perspective, we do have a national strategy. That national strategy is called the National One Health Framework. It has three guiding principles: sustainability, stewardship, and collaboration, both multisectoral and transdisciplinary, but that's at the federal or national level. And by the virtue of working at the federal level, there are 23 agencies that are involved, and that's most of the federal government, are involved in the construct and the thought leadership around One Health. But what I would like to suggest, and this is probably my key message today, is that One Health, as is environmental health, is profoundly local. We heard about the initiatives in Cork, and I really appreciated the illustration of a single farmer and what they're doing around permaculture. What we're finding in the US is that One Health initiatives may or may not be effectively translated from those 23 cooperating agencies at the federal level, that really the individual practitioner who knows their local community really is the most important, potentially most important player in what might be a hyper local issue. We have, and let me give you an example. We now have a practice in the US of people bringing pets into restaurants, animals into grocery stores, and of course, any animal that's an aid to somebody who needs an aid. That's not what I'm talking about. Folks are just bringing their pets in. And who is going to be regulating that? That would be environmental health. As you look at changing environmental conditions because of climate change, for example, impacts on seafood and the changing ecological environment that impacts the food industry, it's the environmental health profession that will be involved in that. And I was very fortunate to be in Patras in Western Greece back in October when we had the opportunity to go to a Ramsar designated wetland to try and control in a very targeted and hyper-local, and you notice I'm repeating that word, hyper-local approach to mosquito larva control. And we worked with our colleagues at Eco Development on that. So the question is in the US, how do we take these broad fundamental vision of these 23 agencies and bring it down to the local level? I'm delighted to say that there are some successes and in places where you might not first anticipate. First, in the heartland, in the center of the country, there's something called the FACES program, which is in essence is bringing One Health education to farmers' children. It is educating the next generation so that they are socialized and normalized in the importance of a healthy environment, healthy animals, and healthy human health. So there is some good news there. And there are progressive states, such as the state of Colorado, which is located in the US Rocky Mountains, where they have the governor signed a landmark One Health agreement that protects public health, animal health, and the environment, because that's really important to the economy, which is something that has been mentioned several times earlier today. What I'd like to do is to close now and just to kind of summarize where the US is at. We have a fragmented public health system. There is not a system per se because of home rule issues in the United States and the large size of the country. This means everybody matters. Kira, if you are in the US, you matter. I matter. What we do at the local level really matters. There is a US national coordinating body, but it's largely animal health dominated at this time. The action and the progress is going to be made at the local level, and we have positive deviance, meaning we have little sparks of excellence. And I gave you a couple of examples of those, the FACES program in the state of Colorado. It's starting to bubble up, but it's not systematically being employed across the country. And then I believe, as I close, that the real opportunities, because public health is throughout the United States, there is a fabric of environmental public health that we inculcate One Health training and education and competencies and objectives into the public health educational paradigm in the 250 accredited units. This would be bachelor's programs, master's programs, and doctoral programs in the United States, that maybe it's now time to integrate systematically those competencies related to One Health. So as the next generation graduates, they can bring the gospel to local agencies throughout the country. With that, Kira, I'm going to give back any time that I may have to you, and I apologize for the slides. Feel free to share those with the attendees after this program is over.
Thank you so much, David. And again, for sharing the perspective from the US, and again, reminding us that we might be two very different regions, but we have a lot of commonalities. And of course, as you said as well, it's really about that intersection between human health, animal health, and planetary health that we need to really hone in on. And then, as you say as well, One Health is indeed local, which is also why I think this webinar is very timely indeed. And colleagues, that lead me to introduce our next speaker, because this is also someone who has really dedicated a lifetime, I would say, not only to public health, but also to governance and, of course, also to One Health. And I'm very pleased to introduce our next speaker, who's Professor Tony Holohan, who is the head of the WHO Collaborating Centre on One Health that's based in Dublin. The Collaborating Centre was designated as one of the first collaborating centres on One Health just last year. And of course, Professor Holohan has been extremely instrumental in making sure that the centre is getting off the ground, and of course also capturing all the evidence that we have, not just in this region, but also globally. And with that, I'm going to hand over to you, Tony. The floor is yours.
Thank you very much indeed, Ciara, and conscious of your time, I'll try to get through things quickly, and as I'm sharing the slides, just might share my thanks to you, and picking up on what David said, that were you in the US, you would matter. I'm glad for my part that you're in Europe, because you matter here too. So thank you very much indeed, Ciara, for the invitation. Can I just check now that...
I am sharing the slides. Can you see it?
Oh, you're sharing the slides. Okay.
Maybe it works better.
Well, that's great, because sharing and talking at the same time challenges my multitasking
Let me know
capacity.
when I should move forward with the slides.
That's very helpful. Well, look, thank you very much indeed, Alvis. Thank you very much. So good afternoon, as I say, and thank you to you and WHO and colleagues in Greece for the invitation. And it's good to see you and so many old, or existing friends, I may say, rather than old, and new ones, and to recognise Giovanni and what's been happening in Italy in terms of the practical steps they've made in making real structural change around a One Health approach in the Ministry of Health in Rome. So, as we know, this webinar is about applying One Health approaches in cities and regions. And this morning we've been hearing about very interesting and different examples around things like preparedness and food systems and zoonotic illness and vector-borne disease and so on. And my argument, one which I think we'll all accept very easily, is that these are not isolated topics. They're different expressions of the same challenge. And the real issue is whether different parts of our systems can work together in a more joined up way to address them. Because for cities and regions, the question is not whether the idea of One Health is an attractive concept that helps us perhaps to understand and arrive at a better diagnosis, if you forgive the medical terminology or analogy. It's whether we can come up with real world treatments that change how people organise or live or play or make decisions or behave. So next slide, please. So cities and regions matter because this is where many of the apparently separate issues that we all understand from a One Health point of view are really interconnected with one another and are experienced most directly at the level of cities and localities, and the way in which David clearly said, hyper-local. So climate change pressures, food systems, planning, biodiversity, local environment, and the lived realities of communities all meet, as it were, at that local level. And this is also where the public will see whether our institutions can work together across boundaries or not. Our subnational authorities are often closer to the problems as well as to the practical levers that can help to improve things. So they can help to connect public health, local government, planning, environment and community actions in ways that national systems, particularly in larger countries, can often struggle to do so. So if One Health cannot become practical at this level, it remains there something which is more conceptual than real. And so really for me it is all about implementation. So next slide please. So in practice, implementation tends to stall for a few very predictable reasons, and people will be very familiar with these. So data are held differently in different organisations that will have different rules and arrangements in terms of access to data and so on, often for very good reasons. Different sectors will use language, culture differently to one another. Culture varies between different institutions and organisations, and of course we all work with different systems of accountability. And while there might be broad support for the idea of working together, there's often no real routine acting together, or one has to, as it were, swim against the tide in order to make progress on working together in those current siloised environments. And as David has helped us to remember, the environmental dimension is very often left at the margins when in fact it should be central. And on top of that, there's often very limited capacity for us to do more than simply to coordinate and to follow through meaningfully and to keep shared priorities identified, in sight and moving together. And we've heard about equity this morning. Often we'll pay lip service to and recognise equity in principle without it being sufficiently visible in the actual decisions in which we're making and holding ourselves to account for that. And there are practical reasons why One Health, these are some of the practical reasons rather why One Health can be easier to describe and to talk about and to get agreement to the concept rather than to implement in practice. So moving on to the next slide please. So what helps in practice? And what helps, I think, is not especially complicated conceptually, but it does require discipline. So we can start, for example, with a shared picture of a local risk that everybody can see. And that's why the example that Denise gave is so wonderful. Rather than separate sectoral views, and choose a smaller number of priorities where collaboration can clearly be seen to add value and where the co-benefits that can arise can easily be seen again. And agree on who owns what across those relevant sectors. So put in place, for example, a regular review mechanism at that level that can solve problems and not simply note their existence. And build engagement, literacy, agency and public understanding early, because that can't succeed only as it were, an internal administrative exercise. If we want these things to work, they cannot work other than in populations who both understand and support. And that we don't get trapped in waiting for the perfect. The perfect is often the enemy of the good, that we get started in things that we know are good enough. And regions and cities can start then in that context with what they have, provided they're prepared to work in a more integrated way. Next slide, please. So if I can just focus very briefly on what we are doing at University College Dublin with the WHO Collaborating Centre. We're trying to build this out in a structured way. So as Ciara says, the centre was launched in February 2024 and designated as a collaborating centre a little over a year ago. We're organising the work through 7 thematic clusters, one of which focuses on urban and rural health. We're still quite early in that journey, and it's important for me to say that, but our direction is clear. We don't want to simply create another space for discussion and deepening of our understanding of concepts. We understand that we need many more disciplines than what we would often see as being the traditional One Health technical sciences to assist with the true challenge of implementation. It has to be something bigger than human medicine and veterinary medicine. We intend to build practical implementation capacity based on that broader interpretation of the disciplines needed that can help to enhance implementation via the research that we do, our teaching, our collaboration, our public engagement, and the habits that working across boundaries is going to need if we're going to prepare people to work in that truly interdisciplinary environment. Next slide, please. And as we've heard already from Denise, Ireland has a useful platform to build upon. Cork has been part of the European Healthy Cities Network for some time. Galway, Limerick and Waterford designated more recently. And we now have 4 designated healthy cities. Alongside that, at the national level, we have the Healthy Ireland Framework, launched while I was Chief Medical Officer in 2013. And that gives stronger national shape to the idea that health and well-being are influenced by more than just healthcare and the provision of health services, and that all sectors have a role to play in shaping health and well-being. And it also brings local government more clearly into that space. And speaking personally, I have always found that local governance understands One Health much more readily and is more implementation ready than central government. And that means there's already a base for a broader and more parallel One Health approach which can connect WHO to member states in a manner that complements the formal connections that exist via Ministers for Health. So we're not starting from nothing. There is an existing local and national architecture that we can use more ambitiously and more coherently. And if I might then in closing and the final slide, to make one simple point, that One Health doesn't need to begin with a perfect structure. It can begin with one simple, shared and well understood local priority and one local plan that can be seen to be relevant. If we want to overcome the implementation gap that I've spoken about, we do need a broader mix of disciplines helping to shape and deliver a true One Health approach. We need the practical insight to understand our systems, our institutions, our collective and individual behaviours, our communications, and not just the technicalities of the problem in pure scientific terms. And then we need the discipline of reviewing our progress together. And I think that's how we can help regions and cities to make One Health real. And then I have on a final slide, I have my contact details for anybody who wishes to follow up with me directly. And thank you again, Ciara, for the opportunity, and lovely to meet you all and the privilege of hearing some wonderful contributions already this morning. Thank you.
Thank you so much, Tony, and thank you for your wonderful contribution, for sharing some very actionable and concrete recommendations, but also sharing with us the work that the Collaborating Centre does, because of course this is really important, because it is a hub that is gathering the evidence on One Health, verifying the evidence, and also is an opportunity to showcase how we can scale up those good practices that we have seen in this webinar today. So thank you very much, Tony. And that leads me to our final speaker, and that is indeed Spyros Mourelatos, who is the CEO of Eco Development SA in Greece. And Spiros, you're going to have the last word and share with us your work around One Health, the One Health approach to vector-borne diseases, focusing on the West Nile virus. So Spiros, the floor is yours.
Thank you for the invitation. It's a privilege and it's an honor. Let me share myself, the screen. At least let me try. I think we will succeed in doing this. Okay, do you see it?
Perfect.
Yes?
Yes.
Yes.
Okay. So I will talk to you about the One Health approach, right, in VBDs, and I will use the paradigm of WNV. And and one speaker told about how the One Health framing is the One Health framing is helping us to do real work, methodological approach. So the 4 organizational layers of eco-development, that is data generation, data leverage, decision making, and interventions, are very well intertwined with the 3 principal components of the One Health, which are the environment and the vectors. From now on, it will be the vector, the infectious pool and the animals. So from now on, it will be the pool and the let's say the humans and the infectious exposure. So eco-development is a company with a substantial expertise in the mitigation of W and malaria in Europe. We have been dealing for the last 15 years, let's say more than 20% of the European human cases of WNV and more than 50% of the human cases in malaria. We have perhaps the largest platform for field-generated data and real-time streaming on mosquitoes. So this is the platform. It is a patented platform. We have 120 field technicians in the field covering 40% of Greece and 20 project managers. And all these people are generating data which are leveraged with big open source data and with the in-house environmental IoTs that we are constructing and are using more and more. So we will provide big data not only on, let's say, larvae, which we do, but also in adults. We are providing 13 million data points every year on the occasion of 3,000 field inspections on 250,000 georeference potential breeding sites. We're 400 people connected in real time, 250 people from 5 regions and several municipalities all over Greece, and approximately 150 people, us actually from eco-development. Our data are structured on these 3, let's say, basic components, right? The vector, so larvae and adult field sampling, the infectious pool. So we're following, let's say, proxies, the backyard young poultry, so as to follow what happens in terms of viruses in the animal pool. And of course, also the MIRs, so as to know which are the percentage, let's say, of the infected mosquitoes circulating. And of course, along with the Hellenic CDC, we have also the privilege to, and the 5 regions we're working with, we have the privilege to, let's say, to deal with 1,500 human cases all over Greece concerning WNV. We also we would like to do, okay, I'm showing here the vector, let's say the vector thing, right? And this is the data leverage, weekly forecasts for Culex larvae. So every week we produce this kind of maps. In red, you see here the high probability of meeting larvae. In yellow, you see the middle probability. And this is what the people in the field are having in their position. And that means that with this tool, we don't go randomly, right, finding mosquitoes, larvae mosquitoes. Larviciding is the mainstream, mosquito control, not only for West Nile virus, for all the mosquitoes that we're treating. And of course, the main thing is if we go randomly in these 20,000, let's say, breeding sites that you have just seen a little bit in green all over Central Macedonia, the success would be 10-15 maximum %. That means we will have 10 to 15% possibility to find mosquito larvae. And with these tools, we increase the probability to 60%. With the best knowledge, I mean, the best experts' knowledge, it should be 40, 50%. So already we are doing much better. Now, let's talk about the pool. So we produce visualizations every week. So here you see on the left a red, this fat red line, which, let's say, illustrates the percentage of, let's say, infected mosquitoes every 15 days. So you see that in 2025, that means in the last year, we had very low circulation of the viruses of the West Nile virus in mosquitoes, right? And on the right, you see these histograms. Here you have the seropositiveness, how we measure it through 250, let's say, blood samples. Every histogram represents 250 blood samples on sentinels, right? On early age chickens, backyard chickens. So you see again, all the years we had, kind of build up of the seropositiveness from June to July, from July to August, but not in 2025. This did not happen on July. So let's say the endozootia did not succeed well, and the spillover also did not succeed. Or I'm using two terms that Paola just used in her presentation. So you see on the right top, the human cases were only 4, and then not, the other years we had from 60 to 240, and this can be explained very well by these two pools, right? And if we get this kind of information, I mean, you see here the sentinels and the MIRs and the ball. I mean, the predictions for the abundances of larvae. We can educate, train, sophisticated models that will guide us where to go. So we have created this aggregate monthly West Nile virus epidemic risk for 54 clusters of villages in the region of Central Macedonia. And this was a model that we are running every month from 2020 to 2025. And that was the AVA system, let's say. And this guides us, and this gives us how, I mean, it guides us where to intensify our larviciding or other actions within these clusters. So in the middle, you have this kind of risk prediction per cluster in 5, different risk levels. And you see on the right how it appeared at the end of 2022. And you see, I mean, for instance, the more grief, it's more than 9 human cases in this cluster. And, the white ones is 0, etc., etc. So we also have this kind, again, we are in the exposure, right? And we try to prioritize our interventions, especially in catch basins in the urban environment. So to do that, we have made a synthesis of the 3 basic, again, risk factors, which are the vector, and the proxy in this case is the catch basins, because the catch basins as the privileged breeding site for the Culex pipiens, which is the vector of the West Nile virus. And then a second proxy is the NDVI, which is an indication of the trees, because the trees are, let's say, hosting the birds, the presumably infected with West Nile virus birds that will come and sleep in the night at our cities. And the third one is the infectious exposure. Here we have demographic, actually we have the age structure per building block. So at the end of the day, we find out, we do the synthesis of these 3, and this is guides us in what would be the prioritization in the totality of the catch basins in big cities. So this is the epitome, let's say, of One Health. And I'll finish up with the actions that we are undertaking, because at the end of the day, what we do is we try to kill mosquitoes or to communicate our whatever results to the people, right? I just wanted to mention here that we do not publish as we would like to, but at least we are sharing our data. So we have been sharing our data from 2020 to 2025 within the system AVA, which was, let's say, awarded with the first prize of the European Innovation Council. And now we have just uploaded our entomological data on the GBFI, which is the Global Biodiversity Information Facility, GBIF. Yeah, which is, and I think we're feeling very good to share our data under conditions, of course, and very, yeah. And what I show you here is to the risk factor, again, vector, infectious pool, infectious exposure, the intervention objectives. And then in green, you see what actually we're doing in the case of WNV mosquito control actions. So as you can see here, and I give you some examples, this is what we're doing. For instance, we are executing, let's say, about 17 out of the 25 suggested actions of One Health interventions in the case in general in VBDs. And this was actually adapted, this slide, from the 2019 WHO manual on operationalizing the health interventions for VBD. So we just try to understand where we are, right? So in the interface, human interface, in the intersection, human interface vector, you see that we're treating. Okay, that's normal. We do larviciding. And in the interface, human interface infectious pool, we are responding, and we do, a lot of actions, extra actions in terms of response protocols for malaria or West Nile virus or whatever it will be presented in the future. And in the intersection, for instance, animal interface and vector, you see that we screen the septic tanks so as not to have this kind of mosquitoes getting into the septic tanks and getting out, and this is on the occasion of, let's say, 20 to 30,000 door-to-door household. And of course, we do other things not by ourselves. As the first example, human interface, intersection, human interface and infectious exposure, where we had distributed with the Hellenic CDC 1,000 bed nets for malaria mitigation. So it's not only for West Nile virus what we do many times, and of course the other thing, which is the environmental, where we collaborate with municipalities in order to clean us the drainage canals. So thank you. I try to be as concise and I say epigrammatic for what we have been doing. So again, I like so much this conceptual from the conceptual framework of this One Health. We're trying to do working methodologies that do not comply but are in conformance, as Dave said, with this kind of principles. Thank you very much.
Thank you so much, Spiros. And again, what a wonderful way to conclude the webinar, because again, you highlighted that you have identified 75 interventions. And I think this really speaks to the importance of this webinar as well, because we're really looking at the very practical applications. So thank you for so generously sharing your knowledge with us. Colleagues, I have not done my job well because we are well over time. I am very conscious that we had decided to also have a part to this where we would have a discussion. Unfortunately, we are going to have to skip that due to time limit, but I want to assure you that we are going to this is just one part of a conversation, and it is to be continued. Our wonderful colleagues in the Western Greece, they will be hosting the Regions for Health Network meeting in November, where we will continue to have this conversation. After the Easter break, there will be a summit in the city of Lyon in France, where there will be a summit on One Health. The conversation will continue there as well. And as a team here at the Secretariat, we will be capturing all the wonderful work that you've been sharing with us today, and we will share that with you in writing as well. I am going to ask my dear colleague Anna to share some closing reflections. And before I do that, I just want to apologize again. Please share your thoughts, your reflections in the chat, and we will capture those. And we will, of course, also make sure that those are shared with our speakers today. Anna, over to you.
Thank you, Kira. I think that the conclusion here is that working from the One Health concept to implementation is above all a question of governance transformation. We are no longer dealing with isolated system, but with interconnected, high risk and dangers that require coordinated responses. So we have to act locally, to have a governance that understand the meaning and the impact of One Health concept. That it is a difficult issue here, but our pillar, I think everybody talks about the pillars. We have to have a regional horizontal growth, everybody talking to each other, the scientific fields of One Health. We have to give a vertical growth about governance, regional, and especially cities. It's a very important, because there is the main operation field, the cities. We have to have evidence-based knowledge with us. We have had an university or institutions. And finally, we have to have with us community people to give people-centered policy making. I think I integrated everything, and thank you very much for this conversation. It was very, very important. Thank you.
Thank you so much, Anna. I would like to thank all of our speakers for again sharing your expertise, your recommendations so eloquently. I'd like to thank all of our participants. We had more than 170 colleagues joining us online today. I'd like to thank you for your time. And I'd like to thank all of you for your commitment to a One Health approach and making that the norm. And again, we will come back to you, colleagues, with all the recommendations that we've heard here today in writing. And then, of course, I'd like to thank our colleagues from Western Greece who have actually been so instrumental in putting this webinar together. And I'd like to thank you for also hosting the upcoming Regions for Health network meeting in November, where we hope to see all of you colleagues as well, so we can continue this very important conversation. With that, I wish you a good afternoon wherever you are in the world. Thank you so much.
Thank you.
Take care.
Ciao,
Thank
ciao,
you very
ciao.
much.
Thank you. Thank you.
Thank you.
Bye-bye.